Hi, everybody. This is Gloria Huang. It's 4 o'clock California time, 7 p.m. Eastern time right now. We're going to give everyone a couple of minutes to so that a few more attendees can join, and then we're going to get started. Thank you so much, those of you who have joined us on time. And I believe that the way things are working right now is that you can hear me speak, but I cannot hear you speak. Because of the number of attendees, we plan to have the attendees muted. But if you look at your login screen, you can see a question box, and we'll be checking that and moderating that as we go along. So I'm going to mute myself now so you don't hear me talking in the background, but in another couple of minutes, we'll get started. Thank you again. For those of you who have just joined on, we're just giving a few more minutes for more attendees to join. I can see our counts getting up there to 26. I think we do expect a few more people, so hang tight. You can hear me, but we cannot hear you. We do have the ability to see questions that you enter in the question box at the bottom of your GoToWebinar screen. So if you do want to communicate to us, please feel free to use that question box. And we'll get started in another minute or two. Okay, everybody, let's get started. Hopefully you can hear me. It would actually be really reassuring if one of you just typed into the question box, "I can hear you," so that we know that you can hear us. And Adam, can you hear me?
I sure can, Gloria.
Excellent. Is anyone responding on the question box? I can't see that at this moment.
Yep, we have multiple people texting in. We got about a dozen people saying loud and clear.
Oh, awesome. Excellent. Then let's get started. Well, my name is Gloria Huang, and Adam there is Adam Tallenfeld, and we are the co-chairs of the SIR Comparative Effectiveness Committee. If I haven't met you before, hope to meet you someday. Welcome to our webinar. It is my great pleasure today to introduce Dr. Lakshika Tennakoon as our invited speaker today. Dr. Tennakoon is a clinical epidemiologist who's currently working in the Department of Surgery in the section of Trauma and Critical Care at Stanford University. She has extensive expertise in clinical outcomes research in the fields of trauma and psychiatry, and her training and work has spanned 4 continents. She studied or worked in Sri Lanka, Australia, England, and now in the United States. We are very fortunate to have her here today as she introduces us to the topic of publicly available large data sets for health outcomes research, pearls, pitfalls, prices, and more. Lakshika, why don't you take it away?
Thank you very much for the introduction, Gloria. So I'm going to start my session. First of all, I just want to talk about thank you. So first of all, I just want to talk about our aims of this presentation. Firstly, we want to encourage use of public data for research. At the same time, we would like to characterize existing large clinical databases. So my next slide is showing the best currently available databases for outcome research. So one is Nationwide Inpatient Sample, it's called NIS, and we have data from 1988 to 2016. NIS is coming under big umbrella of HCAP, that's called Healthcare Cost and Utilization Project. And the second one is Nationwide Emergency Department Sample, NEDS. We have data for 2006 to 2016, and it's coming from HCAP as well. And next one is Nationwide Readmission Database. It's called NRD. It's pretty new data source. It's starting time, they started at 2010, so we have 2010 to 2016 data. It's again coming from HCAP. And then we have KIT inpatient data, and starting year is 1997, and they produce data in every 3 years. We have 2000, 2003, 2006, 2009, 2012, and 2016. And KIT data is coming from the Healthcare Cost and Utilization Project.
And I'm going to jump in and say that we're going to be talking a lot more about all of these databases and letting you know why we're saying that these are the best.
Thank you. So the next one, we are going to talk about National Trauma Data Bank, Mtdb. So we have data from 2002 to 2016, and these data coming from American College of Surgeons. And we have another data set called National Surgical Quality Improvement Program, or NSQIP. These data coming from American College of Surgeons as well. And there are some other data sources I would like to talk about, and they are all coming from the CDC, Center for Disease Control and Prevention. And they are publicly available, and they are mostly free data. So one is National Ambulatory Medical Care Service, or NAMCS, starting from 1993 to 2015. And then we have National Health and Nutrition Examination Survey Enhanced. We have data from 1999 to 2015 coming from CDC. National Hospital Ambulatory Medical Care Survey data, again from Center for Disease Control. And then I am going to talk about some information about Medicare, SEER data, and market scan data, and hospital-based registry data. So I would like to expand more information about the first one is Nationwide Inpatient Sample, or NIS. So this is the largest publicly available all-payer inpatient care database in the US. Sample include all discharges from 20% of stratified sample of US hospitals. This data can be weighted to generate national estimates. So we have available data from 1988 to 2016. And I just want to show you one of the core data file and the size. So we see 7,153,989 records. So,
and that's just 1 year.
Just 1 year, one file. Only one file. It's huge amount of data here. So that's 2015 NIST core data, the size. So let's go back to the cost and data, load software, and all that information firstly. So cost of 2016 NIST data is $625, and original data comes usually as CSV or ASCII files. So there are specific load programs provided by HCAP using different statistical software like Stata, SAS, SPSS. So data storage, remember that these are huge databases. You need a lot of space. So probably you need a server, or if you have a box in your system, so we can save data there too.
So this is a cloud account that you're saving your data in?
Yes. So there are requirements for NIST data or HCAP data. So there is a data use agreement. We have to do a 5 minutes training, and then we need to sign a data user agreement, and we are faxing that to HCAP. So HCAP will give you an ID. You can use this ID for future reference. At the same time, there are some citing HCAP databases rules. So if you want to cite, you use NIST data or NEDS data, you have to follow this style to cite your reference. So they are basically encouraging everyone to do that. Let's go back to the data elements in NIST. So there are 4 data files, major. One is core data, hospital data, illness severity data, cost to charge ratio. It's a supplementary data file, but the main data file is diagnosis and procedure group data. So they have nicely done code books. So I attached a link for the code book. You will see the variables change over time and what is there. I mean, what are you interested as well? So just want to touch the core data file. So we see age at admission, gender, race of the patient, location of patient's residence, the zip codes, and then we see ICD-9, ICD-10 diagnosis codes, and we will see mechanism of injury external codes, ICD-9, and then we'll see ICD-9 CM procedure codes and ICD-9 procedure codes as well. So you will get total charges, disposition, length of stay, and many more other variables. I just highlighted here some important ones only. So then we have second file, hospital data file. So we have hospital bed size, unique identifiers, type of hospitals, hospital location, the status of the hospital, region of the hospitals, and there are some variables for hospital weights. And then there's another file called severity of illness. So it has severity of illness subclass, risk of mortality subclass, and it has 29 comorbid conditions defined by Elixhauser Comorbid Scale. That is one of the standard comorbid scales. And they also have Elixhauser Comorbid software as well. So you can use that one for ICD-10 and ICD-9. You can see the link there. Then we have another supplementary file called cost to charge ratio data. So we have some wage index, some unique identifiers, and some a variable called CCR NIST. That's an identifier linking NIST 2012 to current data to calculate basically total cost. This is based on 2 different variables. One variable is coming from here. The other one is called total charges variable is coming from the NIST core data file. I just put the formula how to generate the total cost using this core data file and the cost to charge ratio data file. Finally, I want to say that we can calculate the hospital cost as well. So just highlighting basically one of the publications they have conducted using IR procedures and NIST data. So I did a search for IR procedures and NIST publications, and I found really few publications, and almost like we have like 4 to 5 publications published in this area using NIST data. So next one, I would like to talk about nationwide emergency department sample NETS data. So NETS is the largest all-payer ED database in the U.S. Samples include stratified sample of 20% of U.S. hospital-based emergency departments. And available data for 2006 and 2016, number of ED visits between 25 and 30 million unweighted records for ED visits from 950 hospitals. So if we weighted, we will get like almost 60 million records. Cost of NETS is $1,000 for 2016, but 2015-14 is cheaper than 16 data.
So under $1,000 for 1 year of data.
Yes, under $1,000. What data elements are in the NETS? 4 data files per year. We have core data, emergency department data, inpatient data, and hospital rates data. So here is a publication based on NETS data. So people publish a lot, but again, I can't find a lot of publication in relation to IR procedures and NETS. So here the nationwide readmission database. This is coming from the Healthcare Cost and Utilization Project, very similar to NIST data. So this will help to calculate national readmission rates for all payers and uninsured, available national representative information on hospital readmission for all ages. As you know, it's very difficult to define the word readmission, but capturing this NRD data source, we can define readmission based on the available data. So we have unweighted NRD data, approximately 12 million discharges each year. So we have core data files, hospital data, illness severity, cost to charge ratio data. Pretty new data set, 2010 to 2016, and cost of NRD 2016 is $1,000. Other data is cheaper than that.
I'm going to jump in real quick because I should have said this in the beginning. I'm sure that this talk is raising a lot of questions. Please enter them in the question box, and when Dr. Tennakoon is done speaking, we're going to answer those questions in the order received. And even though this does have a bit of an IR focus to the talk, and non-IR questions are totally welcome.
Thank you. So here is another publication based on nationwide readmission data and generally some of the IR procedures also here you can see. I can share the slides with you all at any time, but right now I'm just moving on with the presentation. Kids data. So kids data is really important. Basically, this is only all-payer pediatric inpatient care database in the U.S. Contains 2 to 3 million hospital stays. Helps again to develop national and regional estimates on diseases. Data available for demographics, injury characteristics, diagnosis, hospital characteristics, outcomes, and healthcare costs. And we need to sign a data use agreement for all these HCAP databases. And cost of KID 2016 data is $500, and once again, it's all under $500. Here, one of the publications we did recently, I did with my team based on sports-related injuries and their outcomes in youth using KIDS 2012 data, and they are really great. And the missingness is very low and nicely coded and routinely collected data, and it's really great data. And I had great fun of using that data set.
Does this data set also have the Comorbid Scale?
Yes, this one has.
And that's what's really amazing about the HCAP data. It uses the standard of care comorbidity scale, so you really have really granular comorbidity data on all of these patients.
Yes, and at the same time, they use Elixhauser Comorbid Scale, which is a very standardized scale to measure the comorbid functions. So, and they included the software as well. You can get the software for free, download, and then you can use that one if you want to control for confounders at the analysis or any stage. So the next one is I want to talk about National Trauma Data Bank, Mtdb data, the largest registry of trauma patients admitted to trauma centers in the United States. In 2011, 746 7 trauma centers participated. We have data from 2002 to 2016. We don't need a data use agreement for this, but we need to make a small project. At the same time, it's nice if you can have a colleague who is a trauma surgeon, because they have the basically identification as a trauma surgeon, and they have the registered number and all that. So that will help you to get the data more quicker. So just want to say that samples are obtained from the trauma center registries. Most of these hospitals, they have trauma registries. Routinely, they collected data, and they are providing all those data to American College of Surgeons, the head office in Chicago, and they are running this big trauma data bank there. So data files are coming in CSV format, and we can extract the data using Stata or SAS or SPSS. Cost of 2016 Mtdb data is $300.
And so this data requires a submission of a proposal. What's the turnaround time to be able to download this data compared to the HCUP data?
Okay, HCUP data turnaround time is like 10 minutes. Online, we can do all that download using online, whatever the online connection they give to us. And here, basically, Mtdb will take 2 weeks because we need to submit a proposal, and they have to check the proposal from that end, and then they will send us, okay, they accept the proposal, and then we have to pay. So it's, let's say, 2 weeks.
2 weeks if you are a trauma surgeon or have a collaborator who's a trauma surgeon.
Yes.
Okay.
Yes. So what you can get through Mtdb data, this is like a small cross-section. So demographic data, injury severity data, emergency department data, mechanism of injury, ICD-9 and ICD-10 procedure data, ICD-9 and ICD-10 diagnosis data, discharge disposition, facility data, vital signs, protective devices and transportation data, comorbid and complication data. So here there's a paper, once again, used by IR group, and so they used National Trauma Data Bank data, and this is a publication. So we have ICD-9, ICD-10 procedures, so you can generate IR procedures very easily using National Trauma Data Bank data. So here another data source coming from American College of Surgeons. It's called National Surgical Quality Improvement Program, or the NSQIP, a nationally validated risk-adjusted and outcomes-based program. NSQIP has prospective and outcomes data. We have data from 2005 to 2016, and NSQIP will measure and improve the quality of surgical care across surgical specialties in US. 680 hospitals participated in NSQIP in 2017. To get NSQIP data, it's free. You need to have a surgeon connection from your hospital. Let's say your hospital is participating data for NSQIP program, and you have a collaborator, a surgeon, so then you can get this data for free. So what data elements are in the NSQIP? So you have pre-operative risk factors, intraoperative variables, 30-day post-operative mortality and morbidity outcomes, demographic data, and you have CPT, the current procedure terminology data, health and behavior data, and physical examination data. Here in this data set, basically we can generate IR procedure using CPT codes here. So free data for NSQIP participating hospital, and we need to do a data request process using that link, need to sign a data use agreement, and download the data from this link, and it's going to be free. And data files are available in 3 different formats: text data, SPS data, or SAS data. So here, one of the publications they use using NSQIP data. So another data source I want to discuss is Market Scan data. It's a private database and MarketScan is broadly representative of the commercially insured population of US, high quality data, prospective data, and you can get retrospective data as well. So low percentage of missingness, and we have available data from 2002 to 2011, and need to sign a data use agreement, and cost around $50,000 a year.
That's a lot of money.
Quite expensive data source when it comes to HCUP data and National Trauma Data Bank and the NSQIP data. This is fairly expensive to.
And also, not the data is older. The most recent data is 2011.
Yes. And what data elements are in the MarketScan? So you see patient socio-demographic data, admission data and type, diagnosis code, principal and secondary, discharge data, procedure code, length of stay, place of service, provide ID, and data on drugs and medications. So I think MarketScan is very good for pharmaceutical-based research because it has a lot of information about drugs, medications, the dosages, and collected this data retrospectively, and currently they are running data prospectively too. So it's good for pharmaceutical industries than I think IR research. So this is one of the publications they conducted using this data set. Here I am touching SEER Medicare data. So SEER Medicare data is a linked database. Medicare beneficiaries with cancer is the main focus. Data derived from surveillance epidemiology and end results data sources and diagnosis procedure codes are available for ICD-9, ICD-10, CPT, and also they have a healthcare common procedure classification system as well. Patient demographic and socioeconomic characteristics are there. Comorbid functions, breast data or basically cancer data, they have colorectal or breast cancer or prostate cancer data, radiation therapy, chemotherapy data, complications, surveillance, and data sets available from 1991 to 2015. Need to sign a data use agreement. And this is the cost for acquiring data. So you can see it's not that expensive, and they have some restriction at the same time. They have some support. They are giving technical support for data load programs and some statistical advice as well. So this is one of the publications they conducted using SEER Medicare data. So next one is National Health and Nutrition Examination Enhanced data. So they are cross-sectional and high-quality survey data of adults and children in the United States. Data available on nationally representative sample of approximately about 5,000 persons each year. So they have different sets of Enhanced 1, Enhanced 2, Enhanced 3. So they did different levels of service, including different time frames, and at the same time they are running prospective surveys. So you will see they are collecting data right now too. So free to download the data from the CDC website, but at the same time you need to check one of the CDC DUA screen, and you need to follow those instructions. So I will show that one here.
And this is a really small patient population we're talking about. So small number, but they go pretty deep on each patient.
Yes, small number of people. I mean, I'm not saying patients because it's a cross-sectional population-based survey. So it has, let's say, patients, and at the same time, healthy controls or the healthy population people as well. So it's a pretty small sample, and it's a cross-sectional survey. So ideally, we can measure the prevalence of the disease, but not like incidence of something. But if we can get the prospective data, that would be great. But mostly these data collected, and they have a data repository. By the time we download the data, it's going to be retrospective. So what data elements are in the enhanced? So once again, socio-demographic data. They have great dietary data used by using dietary recalls, dietary records, dietary diaries, and all that It's very important data. And clinical examination data as well, medical, dental, physiological measurements, laboratory data, questionnaire data, genetic data, and mortality data. At the same time, they have like restricted data linked to Social Security Administration files and all that. So we can't access those data. They have some restrictions to access some of the data. Generally speaking, it's good to do something like based on, let's say, exposure to some kind of a dietary patterns and obesity, something like that. This would be great. And this is the data use agreement. They have a screen, so you have to read this information and you need to comply with that. So otherwise, they don't have a huge data use agreement to sign and send it to CDC. So this is one of the publications they publish on this, and so you can see some of the variables. It's related to dietary patterns and all that.
And so this data is also very quick and easy to download then? You basically read that screen and then you hit download?
Yes. Yes.
Okay.
And this is National Ambulatory Medical Care Service, NAMCIS data. So this is coming from CDC as well. So National Survey has ambulatory medical care services data in the United States. Data will represent a sample of visits to non-federal employed office-based physicians who are primarily engaged in direct patient care. NAMCIS has high-quality cross-sectional data, and we have data since 1973 up to current. Free to download data from CDC website, again, going through that data use agreement. And again, the data is coming as mostly CSV file or text data, so we can transfer this data to Stata or SAS or SPS based on your interested statistical software. So what data elements are in NAMCIS? So we see socio-demographic data, payment data, primary care physician information data, chronic disease checklist, screening and diagnostic services, treatment and drug prescribed, physician specialty, EMR use and practice parameters, sources of revenues, providers seen and duration of care under those providers. So this is a paper. People publish papers based on NAMCIS data a lot. So another data source is National Hospital Ambulatory Medical Care Service. So this has National Probability Sample Survey of visits to emergency and outpatient departments in non-federal, general, and short-stay hospital in U.S. Records based on survey data producing annual estimates of the number and attributes of visits to hospital emergency departments. Survey is a visit-based and cannot calculate prevalence and incidence rates. So available 1992 to current. Free to download from the CDC website once again, and there are publications done by using this data set. So at last, I just want to say, apart from these ones, I mentioned that registry data. So there are some hospital-based registries. As an example, at Stanford, we do have trauma registry data. So trauma registry data, we have procedure data, ICD-9, ICD-10. At the same time, hospital-based data. At the same time, injury-specific data, demographic data, and outcomes, loads of outcomes data. So we are using trauma registry data for IR procedures, at the same time surgical procedures as well. So probably in other hospitals, they must be having some of these trauma registry databases. At the same time, maybe you see some IR registries as well. I don't know whether we have one here at Stanford. So I strongly encourage to do some research with the registry-based data as well, based on your local hospital. So thank you so much, and I'm finishing my presentation.
And I'm just going to summarize what I've gotten from seeing this talk now a couple of times, because before this talk, I really was not aware of any of these databases. What I've gotten out of this is that the HCUP data, which includes, and we can probably go back to that overview slide of all the different databases, NIST, NEDS, NRD, and the KIDS data, really inexpensive, really fast to download, offers the standard of care Comorbid Scale along with other data, including the cost to charge ratio. And so probably a really good data set for people who want to start on database research, especially if they don't have unlimited funds. The National Trauma Database and NSQIP are good if you're interested in surgical patients or trauma patients. Those require a proposal to access the data. MarketScan, everyone thinks they want that. It's really expensive. The main advantage of that would be the availability of drug data, which may not be as available in the other databases. And then a lot of the other data may not be as relevant to, say, a procedural specialty like interventional radiology.
Yes.
Okay. I'm going to hand it over to Adam now. If you have questions, please feel free to enter them, and we'll start going through those questions and answering them.
All right. Well, thank you, Gloria, for moderating the first part of this webinar, and thank you very much, Lakshika, for that excellent presentation.
Thank you.
I learned a lot, and we have some questions. I'm just going to dive right into them. I will continue to monitor the questions, so if you think of other questions during this discussion, please go ahead and send those. I'll be reviewing those. I have questions of my own, but I'm going to start off by the first question, which was from Ed. Ed asks, how does the nationwide inpatient sample compare to ResDac, to the CMS Medicare claims databases? Dr. Tennakoon, do you want to take the first crack at that? I'm also happy to weigh in. And I know, because I have the attendees list, I know we have some other folks on the call that may have experience as well. So if you have an answer to that question yourself and you want to type that in the questions box, I'll take answers as well. So Dr. Tennakoon?
So nationwide inpatient sample data, I think compared to Medicare data here, the missingness is lower. At the same time, routinely collected data, and we have multiple variables which we can use for our outcomes, and we have cost data. At the same time, we have severity data defined by Elixhauser Comorbid Scale. And most of the time when we do studies, we have to control for potential confounders. Comorbid conditions are a huge problem. So in this, we have already inbuilt Elixhauser Comorbid Scale. So I think that's a very strong way to control for confounders. At the same time, NIST data representing 20% of the study-wide samples of hospitals in the U.S. And I think for me, I really like to work with this data based on these issues.
Do you think it's a more representative sample of the patient population?
Yes.
So I mean,
yes.
Medicare is not representative.
Medicare is representing, but truly I worked. I'm not saying I'm 100% biased, but NIST data, the nationwide inpatient sample data, I think much more richer. I think.
Yeah. What's your opinion, Adam?
I have worked a little bit with the Medicare data. I think I'm not as familiar with the nationwide inpatient sample. It's hard for me to comment on missingness. I think that Medicare data can be pretty expensive is one big difference. I'm really impressed with all the HCUP databases to hear Lakshika say that how affordable they are. Medicare, and I should point out that although we talked about SEER Medicare as a database, that's true. That's a database, but there are as Dr. Boas mentioned, there are separate Medicare claims databases. There's also the SEER database, which is its own entity. So you don't have to just go for the combined SEER Medicare database, which has its own constraints. But I think that a big factor is cost, and the Medicare claims files are available as the 5% file, which is more affordable, but still I think it's thousands of dollars for access, and that incorporates 5% of Medicare beneficiaries versus the 100% claims file, which has all of the Medicare beneficiaries, but is much more costly. So I think that we could probably have a whole other webinar just about the ResDAC files, but that's a great question. I got a question from Michael Brunner. Can we make the slides available? And from Nellie Tan, will the video recording be available online? I think the answer to the second question is that probably yes. We definitely want to make this available, and we'll work with the folks at the SIR Foundation to do that. In terms of putting the slides available outside video format, that's a really good idea as well, and I think we'll talk with Dr. Tennakoon and the SR Foundation folks to see if we can do that as well. Olga Brook wants to know, is there a way to obtain 30 days and 1 year mortality data from the nationwide inpatient sample database?
Okay, so for that question, I think the best data source is nationwide readmission database, because the readmission database has, we can calculate the readmissions for 30 days and at the same time 6 months and 1 year. So using national readmission database, we can generate new variables based on the readmission time, and we can link the mortality to that, so we can find that information. In inpatient sample data, so we have the mortality for that particular year. Let's say if we use NIST 2016 data, we will get the mortality for that particular time period. Yes, we can get that one, but if you want to combine readmission with mortality, I like to recommend NRD. That's coming from HCUP as well. So for the question, answer is yes.
All right. We have another question, this one from Osman Ahmed. Would SEER database include IR oncologic procedures, for example, TACE, Y90, ablation, etc.? If you want, Dr. Tennakoon, I can take the first crack at this one, or I can defer to you.
Okay, you can take, Adam. Thank you.
So to be real clear, because I think that there was another question coming up also about the SEER Medicare database. So I mentioned briefly there's the SEER data, there are the Medicare data, and then there's the linked SEER Medicare database. So what SEER has is it has very accurate and well-validated patient demographic data, and it has very accurate and well-validated cancer staging data and survival data. It has cancer specific and it has all-cause mortality. So you can find out if they died of their primary or of a different cancer or of heart disease. It has less granular data about procedures, but it does, I believe, have some procedural information. I've done work with the SEER Medicare linked files, and those provide more information because you can use the Medicare claims files, including both ICD-9 and 10 codes as well as CPT codes, to identify those procedures. So I know that you can do it with the SEER Medicare. In terms of just the SEER data by themselves, I want to say yes, but I'm not sure. And if there's anybody on the line that's done work just with the SEER data and can answer that question, I'll be scanning the questions text box. We have another question, Dr. Tennakoon, do you have anything to add to that one, or we can move on to the next?
You can move on to next. Thank you.
Dana Haddad asks, are there any imaging data in these registries, for example, preoperative breast MRI prior to mastectomy, lumpectomy, for example? And thanks for the great talk, he says.
Thank you. Thank you for the question. So unfortunately, I can scan all the data sets. So in HCUP data, we don't have any of those data. But in if you have a, let's say, a registry in Stanford, we have a registry. We include some of the scans and everything. And in National Trauma Data Bank also, we don't have any of those information. In all those data sets I mentioned, we don't have these data. But only thing we can find out is if you know the right procedure you want to get, we can generate new variables using ICD-10, ICD-9, CPT, and we can get the procedures for that particular question, but not the pictures or the images is not there. Very sorry for that. So we don't have that information.
That's a really good question because if there's not an imaging database out there, I gotta imagine there's an imaging database out there. But if I want to say that ACR has some kind of something along those lines, or maybe the ACR Research Network, the Akron ACRIN. If you Google, American College of Radiology Akron, I bet that there will be a link to something. But that's a very good question from Dr. Haddad. She also asked another question. Let me see where I can bring it up here. SEER data, is it only Medicare data or does it include other patients? So the SEER files, if you just look in the SEER data files, those are going to be all patients in the National Cancer Institute Survival, Epidemiology, and End Results database, and so that is a patient population that represents about 28% of Americans with cancer, the United States citizens with cancer, residents. If you look at the SEER Medicare data, then that's a one-to-one link of all the SEER registrants who are also in the Medicare claims files. So that's linked with the 100% claims file. So you'll get all of the Medicare beneficiaries who are also happen to be in that SEER file. So it's a smaller population. Let's see here. We have from Varun Danda, what do you think would be the best database for bleeding complications in IR procedures? Lakshika, you want to take that one?
Yes. Okay. Bleeding procedures. Okay. So procedures, of course, we can generate from NIS, NEDS, and all those various data sources. But do you need the bleeding time? Is she talking about the bleeding time and all that? No. Can you please repeat the question again?
Do you think it's procedures that have resulted in bleeding, so bleeding would be a diagnosis code?
So can you please repeat the question again, and I'm sorry.
Sure. Let me see if I can pull it up again here. What do you think would be the best database for bleeding complications in IR procedures? I can say that.
Okay, right. No, I can continue that. So thank you. So when it comes to bleeding, so we can define the disorder for bleeding, right? What kind of a disease we are talking about. So then we have the ICD-9 diagnosis codes and ICD-10 diagnosis codes. So we can define the disease based on ICD-9 and ICD-10. So we have the diagnosis then. And then we want to look into the procedures related to that disorder. Yes, of course, we can get from NIS data, we can get from NRD data, Mtdb, NISQIP, and all these data, we can get the procedures related to bleeding disorders.
You may not be able to get causation, like if you have a diagnosis code of bleeding, you won't know if our procedure treated it or caused the bleeding.
No,
there's no causation.
No causation, but we can do basically an association between bleeding disorders and which procedures are common in these bleeding disorders, which procedures are most used in these bleeding disorders, something like that.
I will say that having used the SEER Medicare files, if you have access to CPT codes, you can, and also ICD-9 codes, there are ICD-9 diagnosis codes, there are also ICD-9 procedure codes. So if you have an ICD-9 procedure code or a CPT procedure code, you can try to parse out an association temporally between when a procedure was done and when a patient needed a transfusion of blood and how much blood transfusion. That can get a little bit dicey. You have to be careful about about how accurate you're going to try and be, because if a patient had many different procedures, there is some variability in the accuracy of the temporality in terms of when a procedure was when a procedure claim was sent, when they put the date for that procedure on the claim, there is some noise in that. So there's a way to do that in multiple databases, I'm sure. It just depends on the devil's in the details. We have another question. This one from Danya Day. Can you please expand on the status of any national IR outcome registries and if it's possible to access them for research purposes? So I saw earlier we had Jeremy Durak on the line. I'm going to see if he's still with us, if there's a way I can unmute him and put him on the spot. He's the SIR Foundation president. But I will say that the short answer is yes. It's going to be harder for me to give you a detailed update on the status, except that the registries are collecting data. There's the ACR, SIR quality outcomes registry, which has been collecting data for a little while now. There's the Vanguard registry, which is a vascular access registry that's spearheaded by the SIR Foundation as well. And I don't know if data are available for use, but absolutely these are registries that are there to be used. So I'll see if I can get a more detailed answer to that question momentarily. Let's see, we have another question from Olga Brook. How accurate is the nationwide inpatient sample database in regards to CT scans performed?
Unfortunately, we don't have CT scan data in a nationwide inpatient sample or any HCUP data sources. So this is a very important question. Another person raised about basically scans and all that. Maybe I will look into this one as well. Some data sources with scanning and all other things. I mean, everyone needs to find out, which we don't have here in HCUP data source. So we don't have.
Very good. We have another question from Ed Boas. What are good funding sources to pay for these data sets? That's a great question. I was impressed at how variable the costs were and how affordable some of these data really are. So it doesn't truly take that much, depending on how many years you want to get, I suppose. But the SIR Foundation has as its mission to promote research into the procedures that we perform. If you are at all interested in interventional radiology related work and research on our procedures and our care, then certainly I would encourage you to reach out to Gloria or me or anyone at the CER committee or in the foundation. And we have, there's, in addition to the annual grant cycle, for which applications are due, I think, in December. And you can go to I believe it's sirfoundation.org. I'll confirm that momentarily, but you can certainly go there and get information about the annual grant cycle. And there's also another mechanism outside that annual grant cycle through the clinical registries, clinical research and registries division and the CER committee, where we can help you potentially put forward a proposal for an individual project or a series of projects outside that grant cycle. So the answer is, if you're interested in doing this kind of research, we want to hear from you. The SIR Foundation wants to hear from you. And it's always tough. The funding is always limited, but that's our mission, is to help all of you, move this research forward. And if your research is on the diagnostic side, certainly I'll be happy to work with you and try and put you in touch with folks either at the ACR or the Association of University Radiologists or RSNA to try and help find funding for that as well. And of course, there's funding outside of radiology as well. We can try and put our heads together offline. Let me look for more questions here. I know we only have about 5 minutes left. Let's see here. So Sharon Kwan adds, regarding the nationwide inpatient sample, it's limited for longitudinal analysis of individual patients. There was also a big methodological change in how the data were collected in 2011 that makes trends analysis difficult. Thank you, Sharon, for that comment, and thank you for being on the webinar. I know that it was not easy for you. And then otherwise, she says, agree with speakers' comments regarding the nationwide inpatient sample. Thank you very much. From Jeremy Durak, do the data use agreements for HCUPs and other data sources have any provisions for wider member access to the data files? In other words, are there any opportunities for SIR or the SIR Foundation to download and maintain files and provide SIR member researchers access? So this dovetails brilliantly with the prior question. Lakshika, what do you know in terms of the ability to warehouse larger quantities of the HCUP data in one repository to then be sort of distributed more widely, separate DUAs from individual investigators?
Okay, I have a great answer for that. So we are doing in trauma already. So we do have a server set up at the School of Medicine, and we got some space for that. So I purchased all these data sources through our Department of Funding, and then I process the data and I use that server as our data repository. So it has so much space and I can save all that data. So then we already basically have set of DUAs and we have interested people within Stanford and outside nationwide. And when we have basically, let's say someone wants to do a project and they will they will contact us, and we do basically provide some remote access to data, and we give the instructions to access the data source and connectivity, and then I will collect all the DUAs and I will get the permission, and so they can access the data from that end once they completed the training for DUA and they sign the DUA, it's done. And then what's going to happen, they can get the data, whatever they want from the data repository. But there is another thing you would need to have. Let's say I am one of IR persons from some other states and I'm going to get NIST 2016 4 data files, let's say core data, hospital data, and severity data and cost to charge ratio data. Now I do have data. Let's say I'm an expert in merging these data, processing data. Then I can do by myself. If not, you need to get statistical or data management, a personal expertise to get that data set processed and set. And then you will have a good data set, and then you will analyze or somebody else analyze. So you need to think about these parts as well. So you can have a repository, even Gloria can have a repository here at Stanford.
Wow.
And so then we can connect all other IR people interested in this research. So probably Gloria can, and I can help Gloria to set up all that as well, if you are interested. So I already did for surgery, so I have great experience with that. You can do, Adam, yes.
All right.
You can help everybody.
We have many more questions, and I want to try and get to all of these if possible. If you're on this webinar and you have to leave, I will make the pledge to answer your question and get the answer from Dr. Tennakoon or myself or another attendee of the webinar if possible, whoever it takes to get that question answered if at all possible, even if we can't do it right now on the webinar. But I'm going to keep going until somebody says we have to stop. So Yoshimi Anzai asks, can you address the sequence of events on these national databases, that is, when the CPT, when the procedure took place by CPT code prior to bleeding complications? I will say that yes, in the SEER Medicare files and the Medicare files as well, I believe, you can identify the timing of the procedure. Again, as I said earlier, if it depends on how granular you want to be. If you have a patient who had a lot of different procedures in a single admission within a short period of time, that's going to be hard. Dr. Tennakoon, do you have more to add to that?
Yeah. So using HCUP data, let's say as an example, NIST, you have like procedure 1 to 15. That means primary procedure, secondary procedure, and tertiary, like that, go on, so on. So, but the timing is not there in HCAP data. But in National Trauma Data Bank, you can see procedures 1 to 32 procedures, up to 32 procedures, primary, secondary, tertiaries, and so on. So then we can generate the timing variable as well, linking to the procedure. This happened in this year at the same time, roughly, let's say the time. We have the time to procedure, date to procedure, year to procedure variables in the National Trauma Data Bank. So answer is using Mtdb, yes, we can do it.
Great. I wanted to get to Akhilesh. Dr. Sista asks, is there a database that could help figure out the number of patients with pelvic pain seen by primary care physicians? Is that something the ambulatory care database could answer, Lakshika?
So yes, using as an example the CDC surveys, you can find even National Health and Nutrition Examination Survey. It has who is your primary care physician. Have you seen your primary care physician multiple times? What was the last primary care visit? So yes, you can get from the CDC surveys.
That's great. And then Sharon Kwan had a response about the SEER data. Thank you again, Sharon, for contributing. She says, generally, SEER data are not granular enough to identify IR procedures, but there may be exceptions. It depends on how they code each specific type of cancer. Dr. Fazeh Sodgari says, I've worked with the nationwide inpatient sample and readmission database. NIS only gives in-hospital mortality data for each hospitalization, so that's very good to know. Thank you for that input. And then we have another question from Dana Haddad. Where did that go? Here we are. Last question for me. She says, that's okay, Dana, thank you. NAMCS screening information, does it include downstream diagnostics and possible surgery and morbidity mortality? She says, sorry, I'm an intruding breast imager. No intrusions whatsoever. So I'll read that question again because it had sort of multiple parts. The NAMCS screening information, does it include downstream diagnostics and possible surgery? Does it include morbidity and mortality data? Dr. Tennakoon, do you happen to know that answer?
Yes, you can get all that. NAMCS has. Yes.
Okay. Olga Brooke asks again, about CT scans performed in the NIS database.
No CT scans.
So sad.
Is there not even procedure diagnosis code? So I don't know about an NIS. I know that in the Medicare claims data, you can get individual CT scans. The issue is going to be identifying why those CT scans were done. If it's an outpatient, you can get that from the outpatient or the carrier files. But those files, more than the inpatient files, tend to have more data missingness. If you're willing to work with that data missingness, you can identify what was the ICD-9 or ICD-10 code associated with that CT scan being done. But they basically,
sorry, I just want to interrupt, Adam. So using this data also, CT scan is if you take as a procedure ICD-9. We can generate that variable. Yes, we can get those data.
Okay, that's good to know. Let's see here. It looks like we've gone ahead and unmuted Dr. Durak. Jeremy, can we put you on the spot to answer a question about the status of the SIR associated registries?
Right. Can you hear me?
Loud and clear. Thanks for contributing.
Okay, great. Yes, I believe the previous question was about the status of the IR registry and specifically about outcomes data. And really that was what was intended with the creation of the National IR Registry. To be absolutely honest, what we're collecting right now is just procedural data. So it's all based on standardized reports. So if you're using the SIR standardized reports and you are enrolled in the ACR monitored IR registry platform, then we can collect those data elements. What we have at present is a committee that's dedicated to creating follow-up standardized reports. So when you see your patients in clinic 30 days after your procedure or whatever time frame, if we could standardize those data elements, enter them into a report that could also be collected into the IR registry, then we can really start to collect outcomes data. And that's our goal. But at the present time, we don't have those outcomes standardized reports. Certainly something we're working towards, and ideally we'd be able to collect that information. I had sent a separate, because I was thinking about the same thing, I'd sent a separate message to Adam and Gloria, just wondering if there might even be an opportunity to join forces with NISQIP, because they have a well-established outcomes registry system. Perhaps we could collect IR procedural outcomes data through them or with some type of collaboration, but ultimately we'd love to get there.
For sure.
Thank you very much, Jeremy, for that input. We have a question for Lakshika, and this is, I apologize, your name is cut off a little bit here on my screen, from Bertrand Jean. The question is, to run queries on the data, did you often have to use languages like SQL, Python, or others, or instead did you limit the data analysis to spreadsheet formulas and use of statistical software?
Okay, so I think the best is you don't need SQL or anything like that. If you are familiar with, let's say, SPSS or Stata or SAS statistical software, so what you can do is one of your use whatever favorite statistical software you can use, and these data sets coming usually as CSV files or ASCII files, you convert to whatever software you like, statistical software you like, and then you analyze using those softwares. So you don't need Python or anything you don't need. It's straightforward CSV, basically generated to SPSS or SAS or Stata files, and then you use straight the statistical software, and then you do the scripting based on the software, and it's easy to learn. SPS is easy to learn, and SAS is a little difficult, but Stata is very user-friendly statistical software, so you can even learn those things easily and you can use, but you don't need Python, SQL, you don't need any of those things. If you know, it's good, but you don't need for this work. Thank you.
Stephanie Dybel asks, with the increased complexity of the ICD-10 coding system, is there any forgiveness in terms of using ICD-10 for your search criteria? Do you have to have the highest level of specificity if using the ICD-10 code? And then a separate question also from Stephanie Dybel, SEER data, is it only Medicare data or does it include other patients? I think we talked about that earlier, or maybe that wasn't Stephanie's question, and that was a copy error. So the first question is, Dr. Tennakoon, with the increased specificity of those ICD-10 of the system, can we still be more general, or does that come as a hindrance in terms of analyzing these data?
Right. So ICD-10 data, I think compared to ICD-9, 10 data more granular. So I think you have to branch it. And as an example, I'm working with some snakebite data right now. So if you go to the ICD-10 code for snakebite, you will see straightforward one big code, and then you will see different basically branches for encounters different, severity different levels. So I think ICD-10 data is good, and we can make a lot of good outcomes using that, going into different levels and very much granular levels. And it's not complex. You have, we can use, I am using Stata statistical software, so I am coding ICD-10 data my best, and I can extract exactly the amount of patients who had that particular disorder or the diagnosis, and then I can branch it out to different granular levels. I think ICD-10 is better. It's not complex. It's going to be great. ICD-9 is great too. I don't know whether I answered the question right. I hope so.
I think that was a good question. And I have more questions of my own, but I don't want to make this webinar unmanageable. Gloria and Sarah and Eleanor, what do you think? Are we under an obligation to cut it off? Should we just keep going? Are there other questions?
How about going until 5:15? Is that okay?
5 more minutes.
5 more minutes? Yes. Please go ahead.
All right. Let me scan the questions here one more time, and while I do, I think we got all of them. I'll make one more check. I'll also say that in terms of comparison of one database to the other, it seems like the HCUP database, the NISQIP, and the National Trauma Database are very easily accessible in terms of the data use agreements. I know SEER can be a little bit more cumbersome, and MarketScan probably is the most cumbersome. But I guess one question I have is would you be able to comment on sort of across the spectrum how overall in like a summary statement how difficult those DUAs are from the various databases by comparison? And the other thing that occurs to me is if I think one thing that would be nice for the whole group, and this isn't really a question, but I think maybe we could make a spreadsheet. It's something that I'll try and do with your help if we could, Lakshika.
Yes,
just
I will help.
That sort of measures a few of these variables: data granularity, data missingness, cost, any potential serious known pitfalls like the issue about the in-hospital mortality for the nationwide inpatient sample, and we could maybe make that available too for everybody so that they can have sort of at a glance, if you will. But I'll shut up now and I'll say thank you again so much for taking the time to educate all of us and to everybody that's participated and contributed to the conversation.
Thank you so much for giving me the opportunity. I really enjoyed it. Thank you.
Thank you very much.
All right, I'm going to make that final scan of the questions here. See here. Nope, we've got that.
Great. Well, while you're scanning, I'm just going to warn those who participated, we're going to send you a brief survey as soon as we can get that together. If you think that this is a worthwhile experience, we'd like to know if you'd like future opportunities like this, and if there are any particular topics you'd like to cover, then please, in the survey, volunteer those so that we can help get that together for you.
All right. I think I had a couple questions of my own that I'm not gonna find quickly on the list of the transcript of everybody else's great questions. This was a fantastic webinar from my perspective, and thanks again to everybody for participating. Gloria, any final words?
I think that's it. Look out for the survey. Thanks so much.
Thank you so much.
Hope to meet you all again in a similar forum.
Okay. Folks at SIR, if you want to go ahead and close it off, I think that'll be a wrap. Thanks again.